We're ready, Joel?
Okay, can you see me?
Your video is not on yet. There we go. All good.
There we go. Okay, so good afternoon, everybody. Welcome to today's Gecko session. Of course, it's hosted by the GI Foundation in association with Project Echo, University of New Mexico. And these sessions are obviously held every Wednesday, and the chat will be open for questions. So today we have Dr. Shamhuyashe from Joburg, who's going to give us a talk on infectious mimics of inflammatory bowel disease. So if you want to start screen sharing, that would be great.
Good afternoon. Can you hear me?
Yes, we can hear you and okay. See you. Thank you.
Okay, so, okay, thank you. Good afternoon. Today's topic on this regular meetings for IBD is on infectious infectious mimics of IBD. So since there's no single gold standard diagnostic test for inflammatory bowel disease, there are many disease processes that can be misdiagnosed as IBD. And also given it's often non-specific symptoms, there's a broad differential diagnosis when considering IBD. So however, most of the etiologies generally will fall into two categories, infectious and non-infectious. So today I'm going to go through a few infectious mimics of IBD. I've got a case which I'm going to present before I go through some of the infectious mimics, and I would acknowledge Dr. Chopdat for giving me the case, which is one of the patients which he saw a few months ago that was in the private practice. So the case is it's a 47-year-old female from Eastern Cape residing in Joburg. She has the background history of IBD positive and also had previous cholecystectomy. She presented with chronic constipation and lower abdominal pains for almost 3 years, and were associated with nausea and episodes of vomiting. There was no PR bleeding or diarrhea. So in April last year, she was admitted at a certain private hospital where she had upper and lower endoscopies done, and which shows some form of colitis, of which the differential diagnosis then made was strongyloidiasis and also gastroesophageal reflux disease from the upper endoscope. And she was also diagnosed with gallstone at that admission and was given an anti-parasitic medication. She was not sure of the name and started on ARVs. Last year, again in July, she presented at the same hospital with persistent abdominal pains, of which she had cholecystectomy done. But this did not resolve. In August, she had hematemesis, constipation, and had a pruritic rash in the hands and thighs, which was worsening. There was no PR bleeding or diarrhea. A repeat endoscopy was done, which confirmed the diagnosis of strongyloidiasis. She was given treatment for 2 days with ivermectin and also a 14-day course of albendazole as an outpatient. So on the social history, she's married with one child. She works in the municipality. She travels to Eastern Cape about 3 times per year, and has got previously traveled to Eastern Cape in 2023 then. She's a non-smoker and non-alcoholic. She doesn't have any allergies. So on examination, her vitals are normal with mild pallor, lymphadenopathy, or any skin rashes. And the respiratory cardiovascular and abdominal, respiratory and cardiovascular systems were normal. The abdomen, she had some mild periumbilical tenderness with no organomegaly. So the workup which was done then, the bloods, she was mildly anemic with an HB of 10.6. The eosinophil count was normal, and also the CD4 count was 116. On the previous, when she was diagnosed, it was 79 according to her. And the inflammatory marker CRP was slightly elevated. It was 11.0. And also the liver function tests were almost normal, except a little bit high ALP. And immunoglobulin E was elevated also. It was 797. And also other tests which were done. Shigella was excluded also together with Campylobacter, and also other bacteria like Yersinia were also excluded, and parasites like Entamoeba histolytica, they were negative. And also PCR, human T lymphotrophic virus 1 was not detected. Yeah, HIV viral load was 130. She was almost a year on treatment. Maybe it was a viral blip because she reported good adherence to treatment. Other viruses which were checked were negative, and also we have other bacteria which were not detected. On stool microscopy, Strongyloides stachyoralis was isolated, and also there were no ova or other parasites which were found on the stool, and C. diff PCR was negative. This is the photo of the gastroenteroscopy and colonoscopies which were done. It's not a clearly visible picture, but from what I can read, on the upper endoscopy, there was extensive inflammation from the stomach to distal duodenum, gastric and duodenal biopsies were taken. And on the lower endoscopy, it shows colitis on the proximal colon, of which biopsies were taken. There were no mass lesions which were noted on this procedure. So on the gastric biopsy which were done, the histology showed that there was they were rhabdomatiform larvae of Strongyloides species which were noted within the gastric pits with moderate inflammation of the residual mucosa. Also, which was observed with lymphoid aggregates. And there was no intestinal type metaplasia, dysplasia, or malignance. H. pylori organisms were not identified. And this slide, it shows the sections of the ulcerated mucosa. It was the colonic biopsy, and which shows that there was glandular architecture which was distorted with a variable loss of goblet cells, and also there was expansion of lamina propria by the inflammatory cells, and also there was an increase in the number of plasma cells, lymphocytes, as well as eosinophils, and the eosinophils and neutrophils. There was eosinophil and neutrophilic cryptitis, but the crypt abscesses were not prominently seen, and also there was Strongyloides species which was noted within the goblet cells. You can see on one of these on the second slide there, in the first one, the first figure, and also on the second one. And also there were some areas of mucosas which shows prominent extravasation of erythrocytes with plump spindle cells. So in conclusion, from the gastric antral biopsy, the findings were those of moderate to marked active gastritis due to Strongyloides species or Strongyloidiasis, with no intestinal metaplasia or dysplasia. And on the colonic biopsy, the morphological features were those of moderate active colitis due to Strongyloides species and Strongyloidiasis. Okay. All right. So these were the findings of the blood findings, and also the histological findings of the specimens which were sent. So I'll move on to infectious mimics of IBD. They can be bacterial, viral, fungal, protozoan, of which one needs to get a detailed clinical history when addressing the intestinal and extra-intestinal symptoms. You also need to get travel history, sexual history, and also assess for conditions which can influence the immune status of an individual. Most of the conditions, they've got non-specific symptoms, and which at times architectural disturbances and basal plasmacytosis favors IBD of infection, that is on histology. And also granulomas, they tend to occur in Crohn's disease, but also there are other wide variety of conditions where you can have granulomas. So you have to broaden your differential when you are waking up such patients. So moving on to strongyloidiasis, it's like many ehrlichiasis. It's The spectrum of clinical manifestation is underpinned by the worm's life cycle in the human host. We have the larva, which is excreted in the stool, and then it develops into free-living adult worms. The eggs are then produced by the fertilized female worms, and also we have the larva, which hatch from the embryonated eggs, and then they develop into an infective filariform. And this infective filariforms of larva they penetrates the intact skin, initiating the infection. So when they are in the circulatory system, they are transported to the lungs and penetrate the alveolar spaces. They are then carried into the trachea and pharynx and swallowed and reach the small intestines where they become adults. So in the lungs, they can manifest like as a Loeffler's-like syndrome, or you can have pulmonary infiltrates with the eosinophilia syndrome. And at that point, patients can also have systemic symptoms, for example, cough, fever, and high-grade eosinophilia. Some might even present like severe Loeffler syndrome, which is characterized by shortness of breath, wheezing, hemoptysis, cough, and respiratory distress. So during the acute infection, you can have a low-grade eosinophilia or a penetrating rash, and when they mature, and after the life cycle, which I described on the previous slide, when the larvae then are coughed and swallowed, they access the small bowel, and where they reside as adult threadworms and females. So there you have an enteric phase of development and maturation, which can be accompanied by the GIT symptoms of strongyloidiasis, where the patient can have epigastric burning pain or upper abdominal pains, and sometimes they can have diarrhea and constipation. The symptoms usually they are not specific. So the mature females in the small bowel, they can produce non-infectious raphidiform larvae, which mature into the gut, into infectious filariform larvae. And then they reinfect the same host via penetration of the colonic, rectal, and perianal mucosa. And such infection can be accompanied by classical pruritus ani that typifies the intestinal strongyloidiasis, and it can be a lifelong scenario. So in those who are immunocompromised, you tend to find that the patient might have a life-threatening disease, even in the acute phases where you can have a hyperinfection syndrome. And also they can tend to have a disseminated disease. So what are the risk factors for a severe disease? Patients who are on immunosuppressive medications like steroids, rituximab, and methotrexate. So from the studies which were done, in view of steroids, it doesn't matter the dose and also the duration of the steroid. And also with it doesn't matter the dose, the duration. Any steroids which are given to the patient pose a risk factor of the patient developing severe infection, especially those who have been we have been infected for a longer period. Or patient with solid organ or hematopoietic stem cell transplantation, they are also at high risk. Those with hematological malignance, and also those with human T lymphotrophic virus infection, of which, like in the case which I presented there, the HTLV infection was negative, but she was HIV infected, which put her at a higher risk, and also with the immunocompromisation which she had, immunoglobulins might have been low. There are some minor risk factors for severe infection, like malnutrition, diabetes mellitus, patients who have got chronic renal failure, and those with heavy alcohol consumption. These were found in minor case studies, which were patients who were being followed up. For the diagnosis, serological testing can be done. You can do ELISA on strongyloides for strongyloides antigen, but also you can find that the patient has got eosinophilia and elevated IgE. You can also do stool microscopy ovine parasites for examination, and also stool PCR, which has got a greater sensitivity. And during endoscopy, you can do duodenal or colonic aspirates, and you do microscopic examination for for this helmet, and also tissue biopsy from the GIT. Other specimens which can be collected where is the urine, CSF, and sputum, where you can look for the strongyloides specific IgG by ELISA. So with strongyloides colitis, it's a severe form of strongyloidiasis where the parasites infect the intestine. And it may occur in patients who are immunocompromised or those who are immunocompetent. And you find that similar symptoms are usually similar to those of other causes of inflammatory or infectious colitis, which can include lower gastrointestinal tract bleeding and non-specific gastrointestinal symptoms. So it tends to mimic ulcerative colitis more than Crohn's colitis. So what does the gastroenterologist have to know in terms of differentiating between strongyloidiasis and IBD or ulcerative colitis, to be specific? So strongyloidiasis colitis, it is characterized by steep pattern of inflammation, and you tend to have distal attenuation of the disease with near or universal rectal sparing, and you also tend to have eosinophil-rich infiltrates of the lamina propria, and also there's preservation of crypt architecture with goblet cell mucin production, and there's a frequent involvement of the submucosa. So these are some of the findings which you may find on histology of patients whom we are suspecting of strongyloides colitis, of which treatment to avoid before screening for those patients who are at risk of dissemination is iatrogenic immunosuppression, corticosteroid therapy, and immunosuppressive medication. Like in the previous case, which I alluded to, they had to wait for the histological results, of which it doesn't take time before they could start patient on treatment, of which the suspicion of a parasitic infection was done, and she never got steroids likely. So IBD, though it was in the picture, she was not given, or she was not started on any immunosuppressions for that. So these are some of the case series which were done. The first one for inflammatory bowel disease, later diagnosed as strongyloides staphylococcus to migrants to Canada. These were patients who were being treated for IBD, for ulcerative colitis, but showing no response. So they did further investigations only to find that the patient had strongyloides colitis, and after change of treatment, given the appropriate treatment, the patient's symptoms, there was clinical improvement actually. And also there was a case of strongyloidiasis masquerading as ulcerative colitis flare. So patient was on treatment, and also it came up as a flare, and people were and there was no response to that flare, of which with further investigations again, it just showed that the patient actually had an other infectious cause. So moving to other infectious mimics, we have got amoebic colitis from the Antiamoeba histolytica, and it predominantly affects the cecum and right colon, but it can affect the entire colon, including the anal region. Patient can present with fulminant colitis, and it can usually develop after systemic steroids, and they have fever, blood stool is absent in most of the cases. And the endoscopic findings, you'll find that patients have got localized inflammatory annular masses in the cecum or ascending colon, and typical of amoebomas. And also they can have flash-shaped mucosal ulcers covered by a shaggy yellowish slough. And also pathologically, you can find amoebic trophocytes with phagocytosed erythrocytes. And it can rarely be associated with penetrating disease causing enterocutaneous or rectovaginal and enterovesical fistula. So for those, the risk factors usually for amoeba is patients who are in endemic areas, those who are in endemic regions like in the sub-Saharan Africa, and also like in Asia or in the South American regions, they are at high risk. Those who are on immunosuppression, and also pregnant women, they are at risk of developing amoeba colitis. And also men, if they develop the disease, they've got a higher risk of a very severe invasive disorder. So these images, the first one, it just shows a large ulcer with elevated borders and a fibrinous center. Which was taken from a patient who had amoebic colitis. And also on the second photo, you can see some trophozoites which are present in that slide, and they are those ovoid, two ovoid, round shaped with the formipel cytoplasm, and usually they have a small round pearl purple, typically eccentric nucleus with a central karyosome. So these are some of the histological findings you can get for a patient with amoeba colitis. The other infectious mimic, which is common in our setup, is TB, tuberculosis, which is the great mimic actually. It may coexist with IBD, or it can mimic Crohn's disease entirely. So you need a combination of clinical history and endoscopic biopsies, culture, and imaging, so that it can help you to differentiate intestinal TB from Crohn's disease. But at times it might not always be sufficient. So you might have a necrotizing granulomas on histology, or necrotic lymph nodes on the imaging, of which those are almost diagnostic. So this table shows some of the features of Crohn's disease versus intestinal TB, of which with Crohn's, it tends to happen to be in the younger age. She has got a relapse and remission course with short duration of symptoms. The patients might have ulcerations and also presence of perianal disease with fistulas, and you might have extra-intestinal manifestations of Crohn's. And also, if you do a tissue TB PCR, it's negative. Whereas with intestinal TB, patient will be having high swinging fevers in the absence of any intra-abdominal abscesses, although fever, it can happen to both. And you might have peritoneal involvement. And of course, if you do a tissue culture, you have a positive TB PCR. And also, histologically, for the radiological features, you'll find that for those patients who have got intestinal TB, they've got short strictures, also with the deformed ileocecal valves. They tend to have lymphadenopathy and also thickened peritoneum. Endoscopically, you find that with TB, there's more transverse ulcers as compared to Crohn's, which has got longitudinal ulcers. And you find nodules, scars, and also short segment strictures. And most of the time, the ileocecal valve is diseased, where you can have a fixed patulous ileocecal valve. And this is a typical sign for intestinal TB. And histologically, you have granulomas, of which for TB, they will be caseating as opposed to non-caseating granulomas of Crohn's. And also there's loss of mucosal architecture close to the granulomas, and you have got a prominent submucosal inflammation. And also on CT enterography, you might find that the short segment is involved. As for patients with Crohn's disease, they might have wall stratification and also some fibrofatty proliferation. Okay. So this photo just shows the tuberculoma. The first one shows a tuberculoma which is centered in the ileocecal valve, and also which it may simulate malignance actually and cause obstruction requiring surgical resection. And on the second slide, you can see a granuloma which are concentrated in the submucosa, which can be large and confluent, as shown in the slide number C. And also rarely you can see bacilli, which can be present on the acid-fast bacilli stain. That's on the last slide. So there are other infections which can simulate inflammatory bowel disease, of which the pathologist has to have a high index of suspicions of these infections. You have got Salmonella typhi, Shigella, and you can also have sexually transmitted disease. You can have Yersinia species and also actinomyces. So you have to find other key features which might be different from the IBD to really pick up these organisms, and with the help of culture, of course. This slide also shows some of the sexually transmitted diseases which can mimic IBDs. We have lymphogranuloma, venereum, proctitis, the same as gonorrhea and syphilis, and you have simplex virus. They can have severe proctitis mimicking IBD. So you have a high index, should have a high index of suspicion for them. So the most common conditions are the ones which I have, which I have covered some of them, but we also have to think of non-infectious conditions where the granuloma is present, like sarcoidosis, and also common variable immunodeficiency. And if someone has got ulcers, you have to think of Behçet's disease. And also with colonic inflammation, it can be diverticulosis, or it can be drug-induced colitis, or it can be ischemic colitis. And also there are some findings where they are non-specific mucosal changes without chronic inflammation, like in irritable bowel disease, and also in patients with cancers, like adenocarcinomas or GI lymphomas, as part of the non-infectious causes. So this slide shows an article which I took from the Crohn's and Colitis Foundation, which was published in the Crohn's and Colitis Foundation, on clinical decision-making in inflammatory bowel disease mimics, practical management from IBD disease live. So since 2009, the IBD specialists have participated in a weekly live video conference called IBD Live, where they would discuss multidisciplinary management of their most interesting and challenging cases. So this conferences, they features robust and interactive cases discussions between gastroenterologists and colorectal surgeons from multiple academic institutions and private practices, and also host global audiences. So in this article, they did a retrospective analysis of cases which were identified as IBD mimics with the consequent clinical management implications. So the studies was carried from 2018 up to 2023, of which they analyzed all the 371 cases which were considered to be IBD mimics. And they were analyzed and categorized according to their diagnostic and therapeutic workup, of which the results, it confirmed that of the confirmed IBD cases, up to 82.5% of them, 193 were Crohn's disease, 107 were ulcerative colitis, with 6 being IBD unclassified. 65 cases were found to be mimics, most commonly medication-induced, and others were vasculitis. And the evaluation ultimately resulted in the correct diagnosis, including endoscopic biopsies and also surgical exploration and pathology, and also biopsies from from extra intestinal biopsies to confirm the diagnosis. So it's the same article. This figure just illustrates the evaluation that resulted in the correct diagnosis of IBD mimics, which was presented in the IBD Live from 2018 to 2025. So additional endoscopic biopsies were done in about 21 patients, and in 21% of the patients, and also surgical exploration and pathology was reassessed in 17% of the patients. And you find that some of the patients even required additional imaging and also deeper analysis of the patient's history, gave some more information, and others required also genetic and other laboratory testing. And also some needed capsule endoscopy to come up with the correct diagnosis. And in terms of biologics, from the same article, find that the biological usage of IBD mimics, which was presented in the IBD Life from 2018 to 2025. Most of the patients will have been tried on biologics, some on one, some on two biologics, and some on three biologics without any improvement, of which, after reassessment and further investigations, it turns out not to be an IBD case altogether. And the biologics which were used mainly, infliximab, it accounted for most of the cases, with vedolizumab being second, and also adalimumab. Some of the cases, it seems like they were given second-line therapies, but with no improvement in the clinical presentation of the patient. And some of the these are some of the category of the diseases which they found out. Most of them were systemic diseases like vasculitis, which were mimicking Crohn's disease. And of the ileal disease, we had lymphomas, and including Kaposi sarcoma, which were also mimicking inflammatory bowel disease, and also the importance of medications-induced colitis, which were mimicking both ulcerative colitis and Crohn's disease. And also ischemic colitis was also found in some of the patients. But besides that, there were some where there was no diagnosis which was made at the time of the publication of this article, but of which there was still further ongoing workup for those patients. So back to our case, the patient was treated as a severe case of strongylitis colitis, of which she was given a repeat course of ivermectin, but an extended course together with albendazole for 21 days. And there was reported clinical improvement on review, though there was no endoscopy done yet to see if the extensive ulceration, which was seen on the previous endoscopy, is resolved. So, in conclusion, there are several common and emerging infections which can mimic IBD at the clinical endoscopic or microscopic level, and of which diagnosis of IBD can be made challenges due to the non-specific symptomatology and variability in endoscopic and histological findings, of which you can have an overlap with numerous IBD mimics. So in that case, the pathologist also we are working with might have a high index of suspicion for infections in the differential diagnosis of IBD from the mucosal biopsies, which they will be analyzing. And in patients with presumptive IBD who do not respond to therapy and have a change in their disease course, clinicians should consider other differential diagnostic possibilities before proceeding to advanced therapy. Okay, thank you. That was my presentation for the IBD infectious mimics for today.
Great, thank you so much. That was an amazing overview. Would you mind just stopping your screen share?
Okay.
Okay, excellent. So there are no questions in the chat at the moment. So I'm just going to couple of comments and some questions. So firstly, strongyloides, to my knowledge, is not endemic in South Africa. And the cases that I've seen have all been from people from elsewhere in the continent. Did this lady have any travel history beyond South Africa?
She didn't have any history beyond South Africa. The only history she has is from Joburg to Eastern Cape, a rural village, not outside South Africa.
Okay. Yeah, I don't know if anybody else has had any cases from within our country, but I suspect it's quite unusual. So you mentioned that strongyloidiasis can closely resemble ulcerative colitis, and in cases where it can mimic an acute severe ulcerative colitis, you alluded to the intravenous steroids can have an extremely high mortality because of the hyperinfection syndrome. In your reading, did you come across any patients that had strongyloidiasis who were accidentally given a biologic or another agent?
I came across one article, but it was from the United States of America, where the patient actually had a acute infection syndrome following steroid use. But here in our sub-Saharan Africa, I didn't get any articles concerning that.
And nothing related to infliximab?
Nothing related to
Nothing
infliximab. Yes.
Okay. And then just a couple of comments. The one is that we can see eosinophilia in IBD, both on the full blood count as well as on biopsies, but it's usually not as high as you see with these parasitic infections. So that's always a clue that perhaps you're not dealing with IBD per se. And then just a couple more comments. The other is that amoebic colitis can be a sexually transmitted disease. I've seen a few cases of that. So also to be considered in that setting. And then the one that you didn't mention, which is schistosoma mansoni. We've seen quite a few cases of colitis due to that pathogen in Cape Town. And it can very strongly resemble Crohn's disease at endoscopy. And of course, on biopsies, you can also see granulomas. So, you know, in that situation, if you've got an eosinophilia and granulomas in the typical sort of patients that may have schistosomiasis, then you need to ask a pathologist to look very closely if they can see the eggs, which of course have the typical lateral spine. Okay, I see something from None. I'm just going to see what he's asked here. He says the definitive host of strongyloidiasis is dogs. Humans get infected from soil contaminated with eggs passed by dogs. Thank you for that comment. And then just my last little 2 cents here. If you are suspecting intestinal TB in a patient who's HIV positive and they have a normal chest x-ray and there are no AFBs, the gene expert's negative, urinary lamb is actually extremely useful in that setting and a very simple test to do. And we just recently diagnosed a case based on a urinary lamb in this particular setting where everything else had come back as negative for TB. Is there anything else, Garners, that you would like to make a comment on, or something that you perhaps had come across in your reading that you thought you may want to share?
Yeah, I think I've shared most of the things which I came across through my reading, especially the importance of the IBD life, which just shows us that people should be aware of these infections. They are there. If the patient is not responding, we need to widen our investigatory. And also the history is very important for some of the patients, especially in areas where some of the some of the infections are rare. So yeah.
Absolutely, I agree with you. So there's just another comment from None. Strongyloidiasis responds well to praziquantel. It's common in the tropics. Okay. So if there's no other questions or comments, I'm going to close this meeting. Firstly, by saying a huge thank you for your excellent presentation. I know how much work goes into putting something like that together, and it was really great. So just also thanks to iEcho University of New Mexico and iEcho India team. The recordings of the session will be available on the Gastro Foundation website. Thanks very much to the Gastro Foundation. Thanks to all of our sponsors, of course. And next week, the session will be pathology. So thanks everyone who joined us. And yeah, been a great meeting and look forward to seeing you again soon. Have a good evening. Bye.